there was a short intermission. So let me just go back to the PIRID score. PIRIDs 1 and 2, the report will come back that it is most unlikely to be cancerous. PIRIDs 4 and 5, a score of PIRIDs 4 and 5 is highly likely to be cancer. And as usual, nothing is completely perfect in medicine. PIRIDs 3 could be either way, okay? But that has improved the way we handle this in a very, very, very different way. So what is the future from what we are now? If you look at the three main areas of treating cancer, surgery, radiotherapy, chemotherapy, and of course you're getting into immunotherapy and targeted therapy. If you look at the radiotherapy aspect, we are now moving into an era of SBRT, which is stereotactic body radiotherapy, and we are going into the phase of high-dose rate brachytherapy. The SBRT is helpful because the IMRT, which we are currently using, you need about 28 to 30 visits to the hospital every single day as an outpatient to get your radiotherapy and go home. With the SBRT, that time period is reduced to 5 to 7 days. But also, you must be aware that if something is given in 28 days, can be done in 5 or 7 days, then the intensity of it is also very high. And therefore, the complications that you suffer with radiotherapy will also be affected. And you must be aware of that. When it comes to surgery, we are looking at doing radical prostatectomies. You know, now we do them laparoscopically, we do them robotically. We do so, and the results are superb because everything is magnified with either laparoscopic or robotic methods, and you can get less complications or a lower degree of complications in terms of urinary incontinence and erectile dysfunction with these methods. And you can now do radical prostatectomies even in what you call oligometastatic disease, which means that if there's a certain small number of lymph nodes that are affected by the disease, you can do the prostatectomy and also lymph node dissection to get good, and this has shown to get good results. Photodynamic therapy to ablate the prostate, these are things that are in the pipeline. When you come to pharma, I talked about PARP inhibitors. This is very much, especially in the younger patients and patients with genetic issues that might give rise to the prostate cancer. And theranostics, I've already told you how that, with PSMA attached, how it helps. Now, although the PSA has been used as a screening method, actually in a lot of the part of the world, it's not a good screening tool. It is good, the PSA, serum PSA level is good to monitor maybe treatment. But as a screening tool, it was being overused with the result that people were being overtreated, and it was not very specific. With the MRI now is becoming more and more popular in terms of screening because it can pick up the early cancers which can be treatable in a more sensitive way than a simple PSA can. And as I speak to you, we have been finding that although we are treating lots of, this concept of overtreatment is real, and therefore the other concept of trying to combat that is what we call active surveillance. And this is now more and more applied to localized prostate cancer that not spread outside the confines of the prostate capsule. And why do we advocate this more and more? Number one, it prevents overtreatment. Number two, it really improves the quality of life by the patients, for the patients, because unfortunately, treatment of prostate cancer involves reduction in sexual function. It involves, when you take testosterone away, weakness of the bones, general fatigue, and general wellness in the patient. So because of these factors, I think when patients are especially in the lower intermediate risk categories, which I have described to you, they would be better followed up by active surveillance. But there are very specific criteria of what active surveillance actually means. And I don't need to go into that here. So with all this information from 4,500 years ago and to the rapid development of evolution of treatment of prostate cancer, what do we do with a patient with prostate cancer today? Unfortunately, fortunately, it's very good news. You go to the basics. The first thing you do is take a good history. Even in these days of PET scans and all these funny things that we do, please spend time with the patient. This will give you a good idea of what is happening, in my opinion, in about 80% of the patients. You can then do, and if you prolong it and do a full examination, you increase that to 85 to 90%. You do a full clinical examination, including a digital rectal examination, because the educated finger can tell you a lot of things. Following that, you do your basic blood tests and urine tests, and including a prostate-specific antigen. And like I said to you before, if prostate cancer is suspected, then the next step is to do what we call, the MP stands for not Member of Parliament, but a multi-parametric MRI, which is done in various segments. It's a very comprehensive test, and which can give you an extremely good idea of what sort of prostate cancer this patient probably has. And following that, you then need to define what is the histology of this cancer, because the histology will then guide you into what category the patient will fall into, whether it is a low risk, intermediate favorable, intermediate unfavorable, high risk, very high risk. Because all those 5 categories have now got different algorithms of how to treat this patient. And that's why the biopsies come in after the MRI. Unfortunately, you don't see the isotope bone scan on this slide because it is now becoming obsolete. Before, up to 5 years ago, it was a bone scan we used to do just to rule out bony metastases. But the PSMA PET-CT is 100 times superior. It will pick up mets in all the soft tissues and anywhere in the body where the prostate cancer has gone. Okay, so it is the gold standard. And I think if there's nothing you guys are going to take away from this talk, is that with all this information in surgical, I've only touched the basics, very basics of surgery, very basics of radiology, very basics of pathology, very basics of chemotherapy and theranostics. You have all this thing in your head. Number one, it's very difficult to remember. So what do we have now? I think as a young institution, I would encourage in your setup to have tumor boards set up. No one doctor knows enough about any cancer to treat that patient on his own. And therefore, no treatment on any patient with prostate cancer should be started by a urologist or a radiologist or a radiation oncologist or a medical oncologist. This patient has to be presented to a tumor board where each person contributes, looks at the screen, looks at the MRI, looks at the pathology, looks at the urea and electrolytes and the biochemical nature of this particular patient. Is he a fit 90-year-old? Is he a decrepit 65-year-old? Those are the things that need to be discussed by a group in the tumor board, which includes urologists, all these other oncologists, radiologists, pathologists, nursing care, and the oncology team. It is criminal, in my opinion, to treat any patient with prostate cancer without passing through a tumor board. Okay? This is, for me, this is your take-home message. And as a young institution, you must try and establish this. As GUTB means genitourinary tumor board. Fortunately, at our Khan, we have a tumor board specifically for genitourinary tumors. We also have a separate one for the breast tumors, a separate one for hemato-oncology. But if you are starting, just start a general tumor board. Start with a general tumor board. But have cancer patients discussed at the tumor board before you start treatment. Okay? So I have borrowed heavily from this first reference. I was looking at how to present this case, and this article by Mika Lehtonen and Pirkko-Liisa Lehtinen was amazing. You can go to it, and it'll really exemplify what I've just been talking to you about. And I've looked at of course, the National Comprehensive Cancer Network, which is normally called the NCCN, the European Association of Urology, and the American Urological Association guidelines on treatment of prostate cancer. So I've actually, by talking to you for half an hour, just scratched the surface of what we are doing and what we intend to do in this field of the evolution. I hope that you have got a little glimpse of what it takes to get to where we are. In our setting, we have had, through the years, 5 Nobel Prizes in medicine guys who have contributed to this. 5 Nobel guys, okay? And it takes a lot, and I'm sure in every field, it'll be the same thing that will be happening. Now, I see a lot more nurses here than I see doctors, but that doesn't matter. Nurses, in my opinion, are the key cornerstone of any health institution. As a doctor, I come and see my patient, if they're lucky, for 5 to 10 minutes in a day. The nurses have to look after them for 23 hours and 50 minutes. I have to rely on them to make sure that the surgery I have done, which is relatively easy, that the patient gets better and gets out of the institution. So I hope that I have impressed upon you what it takes to treat a patient with prostate cancer, and that your inclusion in this is vital. I always say, if I became president today, there are 2 areas of people that I would double, triple their salaries. Number 1 will be teachers. Number 2 would be nurses. Thank you very much.
Please, can we put another hands together once again, more deservingly for Mr. Samnake, who will then ask to just hold on a little bit for a couple of questions.
Sure.
And I want to say that the doctors in the house feel a little bit, don't you think, Dr. Samnake, my first question, don't you think the salary of the doctor should be tripled? Don't answer that one.
I will answer it. No. You increase first the nurses, yes, and the doctors will follow.
So says.
If you increase, because they are the key. They are the key. Let me just tell you.
Indeed, we have to agree that the backbone of any healthcare setting is nursing.
Absolutely.
If your nursing is good, your hospital is good. If your nursing is not good, you're not good. And given that you won an award, can you please give a hand to our nurses? Rkjms won Best in Patient Care across Nairobi County this last year. And I do want to actually take the affirmation from Dr. Samnake. We actually had our 7th tumor board this morning. It's already running, and it's good to hear this kind of approval coming from you without you having known that you're actually doing this.
Yep.
Now, this CME will be watched by many people, thousands, over the next couple of weeks. We are recording it, and we'll ensure that we do it justice. We'll take a couple of questions before I raise my own. Any question from the team, please?
Good afternoon. My name is Dr. Rao. I am from the pathology department. So my question to you is, I have seen that you have clearly indicated the advantage of MRI over PSA. And I agree to that because PSA, as the current edition of Robin says, as far as the name goes, prostate specific antigen, nowadays it is not that specific, because my experience is even in chronic prostatitis, we can see a high PSA. What's your experience with PSA velocity and PSA density, which increases the sensitivity and specificity in PSA testing?
Yeah. So obviously, because when I saw the audience, I didn't want to go into the details of PSA. We can talk for an hour about PSA. Yes, and like you said, the PSA, you said that it is not specific. I said that it's not specific for cancer.
No, actually, it's clearly written in bubbles that PSA, as the name suggests, that it is prostate specific antigen.
Yes.
It is actually not so specific.
Exactly. Yeah. Exactly. No, I agree with you 100%. And so if we go to a higher level of discussion, we have now instead of just looking at what we call total PSA, which I am describing here, you now look at free PSA. You look at PSA velocity, which means how the PSA duplicates or triplicates with time. Okay, you look at the PSA density. In a particular size prostate with a particular PSA, you can then calculate the density of that PSA, which is currently it should be about 0.15. Anything above it, then you suspect prostate cancer. But yes, your point is well taken. These factors make it a little more sensitive to prostate cancer. I'm only talking about prostate cancer. Yes, absolutely.
Thank you very much, Dr. Rao. Any other questions, please? Yes, Dr. Sailesh, then we come to you, Beth.
What is the role of robotic surgery against the other surgeries?
Yeah, so the biggest thing about robotic surgery is that you don't get a big scar. You just get about 4 or 5 keyholes, okay? But more important than that is that it magnifies what you're looking in there. And because you can magnify, because you see a magnified area on the screen, you can operate better, your blood loss is less, in fact, hardly any with robotics, the ones that I have seen. And therefore, your hospital stay gets reduced from 5 to 7 days to about 3 days. So it shortens your hospital stay, mainly, and it reduces cost that way. But for the institution, investment in the robot is a reasonably big expense. So that's the advantage is just what I told you.
Thank you very much, sir.
There's another question there.
Then we come to Dr. Rao.
My question is about the PSA and what Dr. Rao has mentioned that it's not very specific. When we see treatment started or commenced in patients diagnosed with PSA, sometimes if you're using ADT, it flares up and it goes very high. And then you have to start the receptor deprivation therapy. Is it a tool? Can PSA be considered as a tool to monitor response in treatment of prostate cancer? And when you have also, the second question is about when you have already completed the treatment in prostate cancer, which is the best treatment to monitor the patient in terms of recurrence, or up to what time also should you stop treatment? We've seen, as you mentioned earlier, that patients are overtreated so in so many times. So up to what time would you stop? If at all you're doing hormonal therapy, up to what time would you stop the therapy also?
Okay, so I think I want to differentiate between the two aspects of PSA. One is the aspect of screening. It's not a good tool for screening, okay? But for monitoring treatment, it is extremely useful. And that is the way you actually monitor whether your treatment that you're delivering to the patient is working, whether the PSA is going up or down, okay? And still use the PSA if we see a sudden rise in PSA from 0.01 in a patient who has had radical treatment. If it goes to 0.1, we know that that is a 10-fold increase, for instance. And if it goes in 1 month to 0.2, we know that there's something really happening in this patient. So your question, remove this, it is two parts. The screening, it's not a good screening tool, but it is a good tool for monitoring progress and recurrence of the cancer. Progress of treatment and recurrence of cancer. And how long? Again, I would like to refer you to the NCCN guidelines. It's an algorithm of various sorts, depending on the type of cancer you're dealing with, the stage of that cancer. So separate the two, screening and follow-up, yeah.
Okay, before we come to Dr. Rao, and one more question before the end of the CME. I know this is a very interesting topic. Questions could keep coming. The area of theranostics is quite significant, and in particular, lutetium treatment. What's your projection? Because Kenya is known to have gotten nuclear medicine the other way around. We do a lot more PET than we do SPECT, yet SPECT is quite important in diagnosis. SPECT treatment using SPECT as well, nuclear medicine, the areas of lutetium, iodine, these kinds of therapies should be part of what we are doing, but they haven't quite picked up. I do not know what the landscape looks like going forward in your view.
Yeah, no, going forward is, I think I explained what would happen, and theranostics is one of the ways that go through. The most rate limiting factor for these new modern treatments coming in has got to be costs. It's got to be costs. For instance, the olaparib I talked about, the treatment for 1 year for that is almost $150,000. Okay? So the cost is a limiting factor. But Kenyans are very entrepreneurial. And the reason, and I can tell you, we are literally at the cutting edge of management of prostate cancer, where in our setup in the country, than many places in other parts of the world. So I think the private sector is the one that will probably advance the availability of these modern technologies and treatments more than I think the public sector.
Thank you.
But they will come. They will come.
Indeed, I know there is a setup already. Lutetium is coming up in the country somehow very soon. Dr. Rao?
That's what I mean. We are very entrepreneurial. Yeah.
As far as pathology is concerned, just 2 points I want to highlight.
Sure.
First is the Gleason score 1 and 2, which we have shown in the PowerPoint. Gleason score 1 and 2, after the 2014 consensus of WHO ISUP, 1 and 2 are actually gone obsolete, because they say that it depends upon when you are doing a core biopsy, the inter-pathologist variability may be there when you are reading the course, depending upon your expertise and your experience. Second thing is, the treatment module doesn't change in 1 and 2, so that's why they have taken it as with very good prognosis, and actually made it obsolete now. Second is the IHC markers for prostate. Right now we have got a new marker called NK, which is actually the diagnostic marker for one, not any more PSA on IHC.
Okay, there you go. And not only that, I can even tell you that there is now a discussion whether Gleason 3+3 should be called cancer. It has not gone only from 1+1 and 2+2, but even 3+3, the natural history of the disease demands that maybe this should not be considered as a cancer. Yeah.
3+3 and
Yeah.
3+4 also.
Absolutely. Yeah. Good. Points taken.
Thank you so much, Mr. Samna K. It was a privilege and a pleasure to listen to you this day. I want to believe that we should perhaps go ahead and schedule you for the next CME and the next one, if it will be of this level as we usually expect. Asanteni sana, hand of applause please for our
Thank you very much for having
Thank you so much. Again, just recognize the Rkjms team for the good achievement in the County Quality Awards. We won 3 awards: Best in Patient Care, best in HMIS and best in leadership. That's no mean feat, ladies and gentlemen. It means you're going places. For those who've not heard of Rkjms, please find us on 19 Jalaram Road, opposite the Oval in the Parklands area. You can reach us on phone 020-501-2200. Asanteni sana. Thank you very much.
Thank you.